Okay, so let's continue the second half of this class. We're going to be discussing microbial diseases of the respiratory system, remembering, of course, that we've also discussed extensively respiratory diseases of the that are caused by viruses. That's not included in this part. This strictly pertains to bacteria. So we'll realize something, that the respiratory system represents a major route into the interior of our bodies. The other major route to the interior of our bodies is, of course, the gut, the mouth, and the digestive system. But the respiratory system presents one major route of infection. And many of the really important human diseases that we're going to talk about that have had tremendous impact on human mortality, human population size, and human morbidity as well, are acquired via the respiratory system and are bacterial in origin. In addition to the really important viral diseases that we've talked about, you'll realize that the respiratory system is a major center of possible infections that humans can suffer from. So let's just review very briefly anatomy that we need to talk about. First of all, the upper respiratory system, the nose, pharynx, and don't forget middle ear, and the eustachian tubes. It's everything from there on up, basically. And would also include, by the way, it's not put here, the sinuses, those spaces in the bones of the skull, for example, lined with mucous membrane that connect with the respiratory tract as well. Throughout the upper part of the respiratory tract, you will find a very rich and very varied microbiota, which in itself is protective of the upper respiratory tract. It's a normal part of the structure of the respiratory tract. But in addition, both saliva and tears, and also mucus produced in the upper respiratory tract, are all protective of the mucosal surfaces and have direct action. For example, lysozyme in tears has direct antibiotic activity against gram-positive bacteria, especially because it breaks down the gram-positive cell wall. So in the lower respiratory system, from there on down, with the larynx, trachea, the bronchial tubes, then going to the very fine bronchial tubes, the bronchioles, leading into the air sacs of the lung, of the alveoli. Now, the bacterial population of the lower respiratory system is much lower than of the upper respiratory system. And the most of the respiratory tract, apart from the alveoli, is lined with ciliated epithelium. And that is a specialized mucous membrane. There are mucus cells in that ciliated epithelium which produce a continual sheet of mucus, which the cilius of the ciliated cells moves upwards in, it's called a ciliary escalator, continually moves upwards towards the throat and is swallowed. And the function of that mucus is to trap particles, and trap particles as small as bacteria, for example, and prevent them from being able to settle in respiratory tract tissues. Should any bacteria make their way all the way through to the alveoli are by and large sterile, but it's conceivable that bacteria can find their way there during respiration, for example. But there are specialized alveolar macrophages which will phagocytose any bacteria which end up in the alveoli, and the alveoli are pretty much sterile. So the other thing to remember, not mentioned here, but to remember, is that throughout the mucous membranes of the respiratory tract, there is abundant immune tissue. There's abundant lymphatic tissue, which is there specifically to safeguard the respiratory tract. And the most obvious ones are the tonsils and the adenoids, which act as a gateway really to the lower respiratory tract from the upper respiratory tract. Sorry. So here's, let's have a look. The nasal passages themselves are extensively folded with a wide surface area. And that is for various reasons, but amongst the reasons, to warm the air and also to filter it before it passes into the lower respiratory tract, and to trap as much material as possible before air is inhaled into the lower parts of the respiratory tract. The lower respiratory tract begins here. This is the pharynx here. And the one part of the upper respiratory tract that we often forget about is the eustachian tube, which leads to the middle ear, which are really part and parcel of the upper respiratory tract. This is the structure of the lower respiratory system, the trachea here, and then dividing into bronchus, the bronchus dividing smaller and smaller and smaller into bronchioles, and the bronchioles leading to the fine air sacs, richly invested with blood capillaries, which are the alveoli, which are single cell thickness and allow passage of gases really easily. So we expel carbon dioxide and absorb oxygen. But you'll realize something immediately. This is an intricate system. And if bacteria should find their way in here, they can actually do a tremendous amount of damage. This actually happens surprisingly seldom, given the amount of bacteria that we must actually inhale all the time. We inhale bacteria not as single particles as spores, but we usually will inhale bacteria in clumps, either on flakes, skin flakes that are floating in the air, or things like that. And for the most part, until something actually goes wrong, our systems for keeping control of these bacterial populations are very, very good. But of course, it does in fact go wrong, and that's what we need to talk about. So the thing that you will all be familiar with is having a sore throat, an inflamed pharynx, and that is referred to as pharyngitis. The causes of pharyngitis are many and varied. The first thing is, it's tempting to think when you have a cold or you have influenza or whatever, and you get a sore throat, it's tempting to immediately think that you've got a bacterial infection of the throat. That is not necessarily true. Sore throats, pharyngitis can be caused directly by the action of a virus. And very often, most of the symptoms that you feel in pharyngitis are actually inflammatory symptoms caused by your immune system reacting to the presence of the virus in the cells of the mucous membranes. However, that in itself can damage tissues of the upper respiratory tract and of the pharynx, and set up a situation where bacteria can opportunistically occupy the tissues. And those bacteria, the streptococci, for example, that may cause sore throats, serious sore throats, are part of your normal bacterial flora. And they just take, that is a truly opportunistic infection. The tissues are damaged and they manage to flourish in the absence of the normal bacterial flora. If it moves further down and you develop infection of the mucous membranes of the voice box of the larynx, that is laryngitis. And the immediate effect of inflaming the vocal cords is loss of the voice, deepening usually of the voice as the vocal cords thicken. And that is a sign usually that the infection has moved deeper into the lower parts of the respiratory tract. The tonsils are actually part of your immune system. They're in the pharynx, top of the pharynx on either side of of the pharynx. And the tonsils they have a cavernous kind of structure. The way I describe it, they're like combs of tissue with cavities in. And they are really very important guardians of the upper part of the respiratory and the gut. And but they are easily infected, especially in children. They can be infected with various bacteria, which survive deep in these crypts inside the tonsils and set up a really fulminant inflammation, which is often extremely painful and often results in a high temperature as well. This is especially important in children. Now, in the old days, they used to immediately whip out your tonsils. Tonsils and adenoids were routinely removed, even if they weren't diseased, when children were 7 or 8 years old. Nowadays, that is not done so much. Tonsils tend to be left as long as possible or forever. Most of you have probably still got your tonsils. And these tonsillitis, they will be treated vigorously with antibiotics to stop the bacterial growth. That bacterial growth is usually Streptococcus. It can also be another organism called Haemophilus, which we've talked about before, and rarely Staphylococcus can cause it as well. Sinusitis is inflammation of the sinuses. The sinuses are cavities in the skull itself, which are lined with mucous membrane. They connect via ducts to the rest of the respiratory tract. But the problem with sinus infections, with sinusitis, as many of you probably know, is that the ducts that communicate and drain the sinuses are very narrow, and any inflammation of the tissues that's associated with them can block those ducts. And if they do have bacteria growing in them, those bacterial cultures in the sinuses start to actually produce pressure inside the sinus, and it can be extremely painful. Also extremely difficult to treat, because it's very difficult to get enough antibiotic into the sinus cavities to actually affect the bacteria. So it's usually sinus problems are usually treated largely symptomatically, try and reduce the inflammation, get the ducts to open so that they drain properly, rather than anything else, but antibiotics may also be used. So the next thing is very important, and this is something you may not have heard of, and this is epiglottitis. Now, let's just go back here. The epiglottis is here. It's not your uvula. Some people mistake it for the uvula dangles here. You can see it at the back of your throat. The epiglottis is further down, and the function of the epiglottis is to actually close off the windpipe when you're eating and direct food down the esophagus, which is here. Now, there's a huge problem, and it pertains in particular to one particular disease, which we'll talk about in a while. And it's very dangerous in children if an inflammatory condition is set up here on the epiglottis, because the epiglottis can actually swell and end up blocking off the trachea and choking the child. It's really important in children, choking the child to death. This is now something which is very carefully watched for, and it's vigorously treated with antibiotics, because it's an extremely dangerous and in fact, emergency situation if a child develops epiglottitis. That is usually associated with infection around the epiglottis as well, which has a special effect, which I'll describe in a minute in relationship to diphtheria. So just to remind you that the normal microbial flora, just the presence of that microbial flora is protective in itself. It's a very rich, very, very diverse microbial flora. It differs, in fact, from part to part of the respiratory tract. The mouth has a different microflora to the nose, to the back of the throat, and everything else. But effectively, the non-pathogenic bacteria of your microflora outcompete pathogens. Pathogens can't get a hold because the normal flora, they occupy all the space. They themselves produce antibiotics, which limit the growth of pathogens. And then in addition, you have this bronchociliary escalator, which moving mucus up to clear the lower respiratory tract, and then specialized immune responses to try to keep the alveoli sterile. And by and large, that works extremely well. The immune system throughout the immune tract can actually release antibody into the liquids that coat the mucous membranes. So there are distinct immune responses to presence of bacteria, to the presence of pathogens, which the immune system can undertake. So just to remind you, again, a little bit of anatomy. This is ciliated epithelium. You can see the cilia here. These are the ciliated epithelial cells here. Stratified columnar epithelium, those of you who are doing nursing, and it is ciliated. And all the way along, you'll see these kind of clear cells here. These are goblet cells, which produce mucus. Their mucus itself is a very complex substance, strong antibiotic qualities, but it is viscous for a reason. It moves as a sheet. The cilia beat in unison to continually move the sheet of mucus together with all the trapped particles up to the top of your throat where you swallow it. The people who smoke, this is one of the first things that is hit by and damaged by smoking. It affects, first of all, it affects the coordination of beating. The beating of the cilia tends to become chaotic, but in the long-term smokers, the ciliated cells are actually shed and are lost. And when that escalator no longer works, because that you then have to cough the material up to get rid of it. That is why heavy smokers in the morning, all of the stuff is accumulated in their lungs, in their bronchi, and they need to cough it out because their ciliary escalator is not working anymore. A very dangerous situation. Okay, so let's just have a look at some of the diseases which can occur. And there are two things which you're going to hear over and over and over again, two names you'll hear over and over again, and that is Streptococcus and Staphylococcus, but especially Streptococcus in the respiratory system. And there are numerous Streptococci. Let me just tell you that. There are numerous strains of Streptococci. And they are usually distinguished by biochemical means, like biochemical tests, one from the other. And they are indeed, certain strains are associated with particular disease syndromes. So the common strep throat, that is usually members of a group they call Group A Streptococci, GAS, Group A Streptococci. And the commonest member is Streptococcus pyogenes. And Streptococcus pyogenes, you've heard me mention it before in connection, for example, with postpuerperal fever in women. And Streptococcus pyogenes is part of our normal microflora, especially on the skin. And it's when it gets an opportunity to do so, it can set up a disease system by invading throat tissues, for example, of the pharynx. And that is, as I explained, is often in response to damage by virus and immune responses that have caused inflammatory situations to arise anyway. But these streptococci have a number of virulence factors which make them important. First of all, they are resistant to phagocytosis. They have thick capsules, and the macrophages, the phagocytic cells, have difficulty actually seeing them. responding to them to actually phagocytose them. The other thing is that they produce several exoenzymes, streptokinases, streptolysins, various things which have an impact. They are sometimes break down cells, they affect blood clotting, all of these sorts of things, and all of these things in themselves are damaging to tissues and excite even further immune response. So the major responses that you're going to see are inflammation, fever. They commonly cause tonsillitis in children, and the immune response itself, it may be painful. You may have enlarged lymph nodes, for example. It has to be said that these streps do cause sore throat, but in actual fact, there are many other things which can cause sore throats as well. So just because you've got a bacterial infection at the back of the throat, the doctor may often say, oh, you've got strep throat, but it's a generic term for bacterial infection. It's not necessarily streptococcus. To determine whether it is a streptococcus requires careful clinical examination. There are now an ordinary strep throat is usually self-limiting. If it gets really serious, then we usually respond to antibiotics. But unfortunately, there are strains of Streptococcus pyogenes which can produce very virulent exotoxins, which enter into solution in the blood and are conducted around the body by the cardiovascular system. And this is a very interesting thing. This virulence factor, in particular, that I'm going to tell you about, is imparted by infection with a virus. It's a lysogenic virus. Think back to what we said about lysogenic viruses. They can go through a phase where they integrate their DNA with the bacterial DNA, and they don't lyse the cell initially. And the cell just treats that viral DNA as if it's its own DNA. And there's viruses which can carry in virulence factors, and this is one of them. It's a toxin which causes hemorrhage from blood vessels. It causes inflammation of blood vessels and hemorrhage from blood vessels. It is erythrogenic. We visualize it as a rash, for example, resulting from damage to capillaries by the toxin, not by the bacterium itself. You don't have to have bacteremia. The bacterium does not have to enter circulation. It can come from a site like the tonsils or the pharynx, and the toxin goes into solution in the blood and is conducted away. So this produces a particular syndrome called scarlet fever. And scarlet fever is literally that, the skin, the extensive inflammation of the blood vessels and hemorrhage can cause a widespread rash and also a very distinctive reddening of the throat, for example, and reddening and swelling of the throat. This is typical here. This is a pharyngitis, but this is beginning to look like this may also be heading towards a scarlet fever. So here's the scarlet fever, and this is the kind of rash it produces on the skin, and it also can produce a scarlet tongue. In addition to this scarlet throat, it can produce the scarlet tongue, an inflammation of the tongue called glossitis. Now there is this can actually proceed and to an even more dangerous stage, which we've talked about when you talked about cardiovascular, and this is rheumatic fever. And rheumatic fever is a response to this toxin. It's called M toxin or M protein, and it leads, and when it goes into circulation in the blood, it causes strong immune responses in the joints and sometimes at the heart valves as well. And it's also almost like an autoimmune response. The immune response damages the tissues, and it can damage the tissues of the heart so badly that it leads to heart dysfunction. So that is scarlet fever. Scarlet fever used to be fairly common as a childhood illness, because obviously in children, especially, these streptococcal infections are relatively common. They haven't built the resistance that an adult often has to the streptococci. But here is another, this was also childhood disease, although it does occur in adults as well. This is a disease caused by this organism, Corynebacterium diphtheria, and it is the causative agent of the disease diphtheria. You can see here, it's a gram-positive rod, but it does not produce spores. It's one of the gram-positive bacteria that don't produce spores at all. The bacterium, when it colonizes the throat, it actually releases a toxin which has a peculiar effect. It causes very, very rapid production of cells in the surface layers of the mucous membrane, and it causes them to produce a thick glue-like mucus, which glues cells together. It glues dead cells, and it glues layers of bacteria together into what is called a pseudomembrane. It's a response that you see in other bacteria as well. We'll see it in a gut bacteria as well, a Clostridium. And it's a way that the bacterium creates a suitable environment for it to grow in very, very rigorously. Now, this again, the exotoxin is coded for by a virus, and it's only the diphtheria cells that have that viral lysogenic virus that produce this toxin. In fact, our immune system deals with the bacterium very easily. The immune system recognizes the bacterium really easily. And if it does not have this virulence factor, if it doesn't produce this toxin, the bacterium doesn't succeed in producing an infection. But if it does, if it happens that this is one of the bacteria that has been infected with this virus, and they now have the genes to produce this toxin, then it is the toxin that causes all the problems. It's the toxin that allows the bacterium to flourish. And the treatment for this is to give a vaccine, not to the bacterium, not to stop bacterium growth, but to hit at the toxin itself, to stop the toxin from operating. And it's an extremely, extremely successful vaccine, thank goodness, because this disease used to kill thousands upon thousands of children a year. It is a very, very dangerous disease in children. It was once probably the leading cause of infant and child mortality. And in Victorian times, in the 1900s, for example, any family that had children could count on losing at least one child if they had several children. It was one of the reasons people had big families, was because they lost children. People lost children so regularly. Death from diphtheria was a regular part of every house, virtually every household. And the reason for that is that the bacterium producing the exotoxin causes, first of all, a very vigorous inflammation, but it causes the production. Can you see here? This is the pseudomembrane here. And the pseudomembrane can extend all the way down to the epiglottis as well. So it sets up this very dangerous situation in the throat where the pseudomembrane can actually end up blocking the airway completely. And this is exactly what happened to children. They died as a result of the closure of the airway. They simply suffocated to death. There were certain doctors who specialized in removing the pseudomembrane from the throat in order to try and save children. It was a very, very dangerous disease indeed in children. But fortunately now, the children are vaccinated against diphtheria, and it's becoming increasingly uncommon. It was one of the childhood diseases which we'd hoped we would eliminate completely. But in actual fact, in areas where vaccination is fallen out of favor, diphtheria is making a return. But it is treatable by antibiotic as well. So the vaccination is called the DTaP, diphtheria, toxoid, and pertussis. And it protects against another bacterial disease that we'll talk about now, called pertussis. And they are given together. It also, the DTaP also gives vaccination against tetanus, which we talked about before, but that is not a long-lived immunity. That needs to be renewed at regular intervals. The others are much longer lived, but it's a very good vaccination. By the way, oh yes, I thought that I had the figures here. Less than 5 cases of diphtheria in the United States at one point were being reported. It was almost extinct. Unfortunately, that has gone up prodigiously. And there have been minor diphtheria epidemics in various towns where anti-vaccination organizations are particularly active. Okay, so talking about childhood illnesses, those of you who have children, you will probably know about this. Otitis media is bacterial infection of the middle ear. Otitis media is common in children because they have such a narrow, they're small, and they have such a narrow little eustachian tube. The eustachian tube drains the middle ear to the throat, to the pharynx. And it's the eustachian tube that allows us to regulate the pressure in the middle ear. So we continue to regulate, so the pressure in the middle ear is the same as atmospheric pressure. If you block the eustachian tube, that compensation can't take place. But if the blockage is because of bacterial infection, which has inflamed the walls of the eustachian tube, then what you've done is it's effectively set up like a little culture vessel in the middle ear where the bacteria are growing vigorously, creating pressure, which cannot be easily relieved, and it is intensely painful. Earache is maddeningly painful and a source of absolute misery for children. There are various bacteria, any bacterium basically that gets into the middle ear and is able to colonize it and set up that situation. There are numerous of them that will do it. Streptococcus, the various streptococci can do it. But Streptococcus pneumoniae used to be one of the ones, is now less common because, again, there are vaccines for Streptococcus pneumoniae. Haemophilus, Streptococcus pyogenes, and various others that can do this. Because it's difficult to tell what bacterium it is that's doing it very often, children will be treated with broad spectrum antibiotics to try and relieve it. If the inflammation doesn't go down quickly, or if it's so repeated that the child can't clear, this is the sort of thing you see. This is the tympanum here. This is looking down the outer ear canal. Here's the tympanum, and the poor little thing, this bulging eardrum looking like it's ready to burst, which it can do under extreme cases. If this is a persistent problem, if it doesn't get quickly relieved or whatever, then very often what they will do is they will put in grommets. They'll punch a hole in the eardrum, and they put in a little plastic ring that keeps the hole open for a certain amount of time. Eventually, the eardrum just heals and drops the grommet. doesn't have to be removed, but that allows the middle ear to compensate for the pressure. And if there's a bacterial infection in here, it allows the infection to drain out, make it much easier to treat, much quicker healing as well. Okay, so those are a couple of the things of the upper respiratory tract. And you'll notice that we didn't there discuss anything except for diphtheria, which is particularly dangerous. The upper respiratory tract bacterial infections, especially nowadays with the presence of antibiotics and everything, are usually of lesser concern. However, as you move down the respiratory tract, as you go into the lower respiratory tract, bacterial infections become increasingly more dangerous. This can be caused by many of the same causative agents that you have in the upper respiratory tract. But the lower respiratory tract is kept largely bacteria-free under normal circumstances. And if bacteria move down into the lower respiratory tract, it can be a very serious situation, as we'll hear. There are things which we are used to hearing about. Bronchitis is inflammation of the bronchi, but bronchitis can arise from any source. It can be viral, or it can be bacterial as well. And very often, any inflammation like that, the lower respiratory, any bacterial inflammation of the lower respiratory tract often follows on a viral infection. And one of the reasons for that is a viral infection spreads much more easily because it's often systemic, causes inflammation in the lower respiratory tract, and that shuts down or partially disables that mucus escalator. And bacteria can settle into inflamed, damaged tissue and set up residence. If they do in the bronchi, they usually produce a violent cough. Bacterial infections of the lower respiratory tract are by and large productive. They cause abundant mucus production. That is not always true of viral infections. Viral infections can cause inflammation and cough, but they usually produce a dry cough, not a productive cough. That is why a doctor will always ask, are you coughing up like green mucus if you've got a bad cough? It's an indication that you may have a bacterial infection that has settled in the bronchi. Bronchiolitis is less common. It's inflammation of the smaller bronchioles. Most of these, for most of us with a healthy immune system and everything else, even though it may be agonizing to have a cough for days and everything else, that cough itself is protective. You're continually bringing up bacteria trapped in the mucus. Even though the escalator maybe not be working that well, the cough itself is protective, or even though it's unpleasant and may be painful. But as you move to bronchiolitis, this is more serious because now, if you start to inflame those small bronchioles that are leading to the alveoli, you run a grave risk of starting to impede airflow in and out of the bronchioli, out of the alveoli rather, and you risk actually kind of shutting them off and allowing any bacteria which are present in the alveoli to begin to reproduce. And once that happens, there is often a very strong immune response. The alveoli become inflamed. Fluid starts to flood the alveoli. If they're not draining properly because bronchioles are blocked, then we are in a very dangerous situation where we begin to look at a pneumonia, a fluid-filled alveoli with bacteria actively growing in the fluids. And that is a classical pneumonia, and a very dangerous situation because that pneumonia can spread. It can spread through entire lobes of the lung and then from lobe to lobe of the lung. And pneumonias are a frequent cause of mortality. They used to be one of the leading causes of mortality in the elderly. Sadly, they used to refer to these pneumonias as being the old person's friend, because in very, very elderly, bedridden people who were not clearing their lungs properly, these pneumonias often set up almost overnight and were fatal within days and just carried the old person off. So a pneumonia is a situation where the pulmonary alveoli themselves are infected or affected and are inflamed, leak fluid, become blocked, and the whole uptake of oxygen becomes seriously affected. There are various causes which we'll hear about in a minute. Okay, so here's another common childhood illness caused by a bacterium, but also dealt with by a vaccine, efficiently dealt with by a vaccine. And this is whooping cough. This is Bordetella, and it's Bordetella pertussis. It's a gram-negative rod. Here it is here in the scanning electron micrograph, and you can see this is its typical habitat. It infests the ciliated cells of the lower respiratory tract. That in itself is the result of a virulence factor, a capsule component, which allows the bacterium to attach to the ciliated cells. Bordetella produces many, or several, I wouldn't say many, produces several exotoxins. And unfortunately, one of the effects of these is that it hits at the ciliated epithelium it is settled on, kills those cells, and it shuts down that ciliary escalator. And that toxin in itself is pyrogenic. It causes a higher fever, and goes into circulation and causes various systemic effects. But the impact of shutting down this mucus escalator and causing inflammation in the lungs, in the trachea and the bronchioles, is that it sets up a violent cough, which is very, very distinctive. This begins like it feels like a normal cold, appears as if it was a normal cold, but it very rapidly moves to this stage where it infects the ciliary cells, ciliated cells. And when that happens, the child will begin to cough in a peculiar way. They'll cough and cough and cough and cough and cough. And they'll cough so violently that they'll squeeze all of the air out of their lungs. They often ball up like this, and then they'll try and take a breath, but the trachea and everything are inflamed. And as the air whistles through the bronchi, the inflamed bronchi, it makes this whooping sound that goes, like as they're desperately trying to take a breath. It's very, very distressing to watch, and in young children in the old days, it could be fatal. That toxin in circulation causes various systemic effects, and often the recovery from pertussis, from whooping cough, was very long and very slow. And fortunately, this is one of the vaccines that is included in the DTaP. So there's a diphtheria, tetanus, pertussis. There it is there. The P in DTaP stands for pertussis. But whooping cough now is not that commonly seen, except again, it is recurring in areas where vaccination is unpopular, but it is treatable with antibiotics. But the problem is it needs to be recognized early. Once it reaches this stage, the damage really is done already to the ciliated epithelium. And by this stage, also toxins are in circulation in the blood. Pertussis was formerly a very serious childhood illness, common. Obviously, many children survived it perfectly well. but it was definitely a significant cause of mortality and certainly of morbidity. Some children were very, very badly affected for a very long time. Okay, so we now need to talk about this disease, which you've all heard about before, which is tuberculosis. Tuberculosis, TB. In modern times, we tend not to hear that much about it, nor to think about it that much. It's very difficult for us to picture what life was like, even in a city like New York, 100 years ago, when tuberculosis was incredibly common. It was extremely common, even in wealthy society, although less common in wealthy society than in the poorer societies. And the reason for that was it's strongly associated with crowding. It's not actually that contagious. And you need pretty prolonged exposure and pretty close contact with somebody who has the disease in order to acquire it. Nonetheless, it was present in all classes of society. And in fact, it was so common that there was a kind of an industry, especially here in New York, in the state of New York. In Upper New York, there were many, many sanatoriums which were built to try and help people who had acquired tuberculosis. So in our societies now, we don't see tuberculosis that often. If somebody does suffer from tuberculosis, they are often just treated. They're treated with very strong antibiotics and can remain circulatory. They just carry on doing their jobs and everything else. They're not infectious once they're on antibiotics, and so life can go on as normal. In the old days, identification and then isolation were really the only way that authorities had to try and control the spread of tuberculosis. And people would, in fact, be taken away, would be forcibly hospitalized until they could be declared free of the disease, which for many of them never happened, for reasons that you'll see in a minute. There were certain things they did hoping that the disease would be eliminated, but with limited effectiveness until we got antibiotics. So the causative agent is Mycobacterium tuberculosis. And this is another mycobacterium. We talked about Mycobacterium leprae before. This is another genus, Mycobacterium, and it has the same characteristics as all the mycobacteria. It's an acid-fast rod. It has mycolic acid in the cell wall. Doesn't respond to the gram stain, so it's stained with a special staining technique, and it stains red after treatment with acid, and it is an acid-fast rod. So it's an obligate aerobe, which is a kind of makes sense that it can infect the lungs, but it doesn't make such sense when you see how the disease process works. You'll understand what I mean in a minute. It's another of these bacteria that have a long, slow growth. The generation time is about 20 hours under ideal conditions. It's very slow growing. And in fact, in the initial stages, disease progression is slow. It is quite difficult to treat. It is, first of all, it's quite difficult to kill in the environment. It's, the mycolic acid is quite protective for disinfectants and things like that. But those, they also do not respond to ordinary kinds of antibiotics. They need a special class of antibiotics. There are some other mycobacteria which will cause similar disease. Bovine tuberculosis can occur in human beings, and it was another of the reasons why Pasteur set up the system of pasteurizing milk, because brucellosis, which was transmitted by milk, sometimes accompanied by bovine tuberculosis, and it could infect human beings. This bacterium, in fact, the bovine tuberculosis, it was formed the basis of a vaccine for human beings. Not terribly successful vaccine, but I'll mention it in a while. There are various other mycobacteria, by the way, which some of them are just commensals, part of our normal bacterial flora, don't do anything at all. This one is kind of interesting, MAI, Mycobacterium avium intracellulare. This is a group of mycobacterium strains which infect people who are immune compromised. So this MAI, it's referred to, is a symptom of AIDS, for example. It occurs in people whose immune system has collapsed. So yeah, here is Mycobacterium tuberculosis, acid-fast stained, and it produces a blue background to the cells and everything else. And then you see the cells all lie stacked up together in palisades. It's called palisade growth. They lined up like this, and it forms these distinct clumps or cords of cells. This is a toxic bacterium. Even a small amount of bacteria growing in the lungs release quite a few exotoxins, which produce a complex of symptoms which are quite typical, such as night sweats, nighttime temperature rises, profound fatigue, and those sorts of symptoms. So that it has, even with a small focus of infection in the lungs, it has a systemic symptomatology. This is how it works. If you inhale the bacterium, it is very quickly recognized by macrophages in the lungs, and it's swallowed by the macrophages. But unfortunately, the macrophages survive ingestion, and they begin to reproduce inside the macrophage. Eventually, well, what happens when the macrophage phagocytoses a pathogen is it releases hormones to inform the rest of the immune system that something's going on, something has been spotted. In the case of tuberculosis, other macrophages begin to flock in to surround the infected macrophages. And now what happens is that some of those infected macrophages begin to die, and they begin to burst and spread the infection to clumps of macrophages surrounding them. So it forms a distinct clump like this. And on the inside, there's often a space where cells have died and where the tuberculosis bacteria are reproducing, but they only reproduce very slowly. They are aerobic, and this is rather anaerobic, and it limits their growth. This is a slow process. And it forms this, what is called a tubercle, and it's very distinctive for tuberculosis. That tubercle can arrest. It can, what often happens is that the cells almost go dormant in a way. Inside, the metabolism slows way down in the lack of oxygen, and the body may respond. This sets up like a constant small inflammation. The body may respond by depositing calcium around here. And if the person's really lucky, then this entire tubercle will become calcified, and the bacteria become isolated on the inside, and nothing more happens. Now, this was the great hope of treatment for people with early stage tuberculosis. They used to put people onto bed rest, for example. If possible, send them to a sanatorium. There was this belief that if you were high up in the mountains, the air was healthier for you, and it encouraged the infection to become latent. And if on X-ray they could see that the infection was surrounded by these calcium deposits, thick calcium deposits, then the person could maybe go back to normal society. But unfortunately, this bacterium can continue to cause necrosis of this tubercle and end up actually causing a necrosis of surrounding tissues. And so what happens then is that the center basically liquefies, and you get bacteria released, for example, into the bloodstream, very quickly transported to other areas, localized, other areas of the lung, for example, where they settle, and they do the same thing all over again. And it may also put bacteria into the lymphatic system and into the general circulatory system. And you can get foci rather, of tuberculosis occurring all over the body, in the bones, in the organs, in which case it is called miliary, M-I-L-I-A-R-I, miliary tuberculosis. So that's the kind of the disease process. Once the spread begins, the progress of the disease can be extremely fast. So characteristically, people with tuberculosis might have a very long period that you might think of as being the prodromal period, when this initial infection was being set up, and then a very rapid progression as the disease begins to spread, especially through the lungs. So this is the kind of thing that you would see. You'd have a focus of infection. Lung tissue would eventually start to be destroyed in the vicinity. The bacteria are spread through the blood circulatory system and just by a normal spread to the tissues around them. And they end up in the end causing these cavernous holes in the lung tissue, as whole areas of the lung tissue begin to become necrotic and to die. Very, very frequently, death results when the bacteria cause the rupture of a major blood vessel in the lung, and people would die by a hemorrhage. That was a very, very frequent cause of death. You'll notice that in this diagram, the progression is by lobe, but then it can spread, of course, to the other lobe. Another form of treatment was at an early stage like this, when it was well isolated in one part of the lung, you could actually have that lobe removed by surgery, or else you could have this lung would be collapsed, and the lung would then stop functioning as a lung, but this tissue would all become scar tissue, would coalesce into like connective tissue rather, and isolate this focus of infection away from the rest of the lung. That was a frequent treatment. There was a vaccine developed fairly early on. It's called the BCG, Bacillus calmette-guerin, and it's named for the doctors who developed it. And it's actually that Microbiocterium bovis, the bacterium that causes tuberculosis in cattle, very, very much weakened. And it has been used. It confers some protection in children, but it does not last. It's widely used in Europe, Africa, but is not used here in the United States. And it really has very limited impact. So there are different ways of diagnosing tuberculosis. People with tuberculosis often present with those symptoms: night sweats, intermittent fever, fatigue, that sort of thing. And where tuberculosis is common, that's easily recognized. But there are some specific tests. The one is to give a small amount of proteins derived from tuberculosis underneath the skin and see if there's an immune response to it. If there is, it produces an inflammatory response, which is visible. And you can actually then say, well, this person either has current infection or else they have sometime been exposed to tuberculosis, and then proceed. X-ray, computerized tomography exam, that sort of thing. But still a standard method of treatment is to do a deep sputum. You get people to cough from deep, deep, deep in their lungs, to really, 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 really cough for a long time, 10 minutes, 15 minutes, and bring up a sputum sample from deep in the lungs, which is then examined with acid-fast staining. But you can also culture, although the culturing is difficult. It's very fastidious bacteria. There's also serology tests that you can do, various other things. Diagnosis these days is really pretty good. But unfortunately, in third world countries, many of these methods are not available to them. TB is incredibly widespread all around the world, and it is still a major cause of human mortality. And those two diseases, tuberculosis and influenza, between them have probably exerted more pressure on the human population than any other diseases. This is the tuberculin test. They've given it here, and then they see how strong the immune response is to it. It's measured. If it's a strong response, you've either been exposed once upon a time or else you have active TB. This is one of the disadvantages of using the BCG vaccine. In countries where BCG vaccine is widespread, you can't do the tuberculin test because they have been vaccinated, so they will produce a strong response. The treatment for tuberculosis is extremely lengthy. Even in modern times, treatment is at least 6 months. These drugs, they're called the first-line drugs. These were the first ones to be developed, and they were revolutionary. This was the first time that TB could actually be treated, and it was soon realized that under these treatments, isoniazid, rifampin, these things, under these antibiotic treatments, people very, very soon lost their infectivity. They couldn't infect other people. So it meant people under treatment could actually lead normal lives, not be shut away somewhere in a hospital for 6 months away from their families, which was standard in the old days. Unfortunately, Mycobacterium develops resistance very, very quickly. And we've seen over the last 75 years or so, we've seen the development of many, many resistant strains of tuberculosis. Each time resistant strains arise and begin to make their way through the population, new antibiotics are tried, but we now have ended up with strains, first of all, multiple multi-drug resistant strains, which resist all of the first-line drugs, and then extensively drug-resistant strains, which are not only resistant to these first-line drugs, but to the more modern ones as well, to the second-line drugs as well. And there are many cases where drug treatment now is simply failing because the bacteria themselves are so extensively resistant to antibiotics. Tuberculosis is incredibly common. 10 million people a year develop tuberculosis, and currently that is a gross underestimate, I'm sure. Many, many people, I know, but many, many people in Africa, for example, and probably in Asia and India and all over the world, will die of TB without ever being seen by a doctor. They're never diagnosed, they're never treated. The most extraordinary figure is that 1/3 of the world's population has some sign that they have latent TB. That is how common this bacterium actually is. But many people just react so strongly to the immune system, reacts so strongly to it that they almost immediately isolate it in one of those latent tubercles, and it does not proceed. This in itself, however, is a problem because those tubercles are maintained by the immune system. They're established and maintained by the immune system. And in places where HIV is common, for example, in Southern Africa, look, Sub-Saharan Africa here, HIV is extremely common. And as people become immunocompromised, very frequently those latent infections explode and they become fulminant. And those people become extremely infectious as well. They release a tremendous amount of bacterium because their immune systems are not fighting it at all. And the two plagues together, HIV and TB, are very much tied to one another, unfortunately, and have resulted in mass mortalities, especially in Southern Africa, but in India and the Far East as well. Okay, so let's just talk briefly about the bacterial pneumonias. Bacterial pneumonia also used to be a major cause of human mortalities. And there's one particular group of bacteria which are associated with it, and this is also Streptococcus. This is Streptococcus pneumoniae. Streptococcus pneumoniae is a gram-positive coccus. It's a diplococcus. It appears as two cells joined together. And there are different strains. Some of them cause pneumonia, others do not. The ones that cause pneumonia have a big, thick capsule around the cells. And that capsule, possession of that capsule is a virulence factor. It allows the streptococcus to adhere to lung tissue, number one. And number two, it shields the bacterium from attack by macrophages. And there are some other organisms which will also cause pneumonias. They are referred to as the atypical pneumonias. And one of these would be Haemophilus. But you can even have Staphylococcus causing pneumonia under some circumstances. Very often, like visualizing it on X-ray, you'll see that pneumonia is isolated to a particular lobe of the lung. It spreads through the alveoli, but remains isolated, initially at least, to a particular lobe. And which often they'll say that is lobar pneumonia. But if it lies closer to the main bronchi, often is associated with heavy coughing as well. That is bronchopneumonia. The bacterial infection can actually spread throughout the lungs and end up close to the surface of the lungs. And if it does that, it can excite an inflammatory response, which inflames the pleura, the linings, the serous membranes, which line outside of the lungs. And this causes an intensely painful condition called pleurisy, and often associated with coughing. So it is very, very, very debilitating. Now, where it's caused by Streptococcus pneumonia, it's called pneumococcal pneumonia. And it is often the result of, it's often a secondary infection after another infection, like a viral infection. It is also a grave danger in patients who are on long-term bed residence. When you've been lying down for a long time, this whole mucociliary escalator is disrupted. The clearing of your lungs is disrupted. And fluids begin to accumulate in the lungs. Even the alveoli are not properly cleared. And once that happens, then the situation is ripe for bacteria to now infect the alveoli and cause a pneumonia. And as the pneumonia itself literally fills those alveoli. It can be visualized on X-ray that the alveoli have become totally filled with fluids, and of course are useless for oxygen uptake. This was, as I told you, the major cause of mortality in the elderly This was really the standard way, almost. The final illness of the very elderly was usually pneumococcal pneumonia. Nowadays, it is easily treated, at least the bacterial infection is easily treated. Some other aspects of the pneumonia are not so easy to treat, and in particular, that's the immune response. And part of the filling of the alveoli is due to immune response. Inflammatory responses in the walls of the alveoli lead to the blood vessels becoming leaky to serum, and that fills the alveoli. These kind of inflammatory responses themselves can be extremely damaging and are quite difficult to control, where the pneumococcus itself may be responsive to antibiotics. However, this is now becoming less common. Streptococcal pneumonia is really becoming a thing of the past, because there are very good vaccines against Streptococcus pneumoniae. We've had vaccines for a long time, and if this will be in the distant past of this semester for you, but I told you about Griffith, who did his work on DNA of Streptococcus, development of the capsule and non-development of the capsule. He was working on a vaccine, and he developed a vaccine. So we've had vaccines, but not effective. It's only recently that we've developed extremely effective vaccines, which, as you get to my age, everybody is advised to have. This is the organism itself. And you can see around it this thick capsule there. This is a single cell here. There. This is, and it's difficult to see in this preparation, but it's a Diplococcus. There's one cell there, and there's one cell there with a thick capsule surrounding it. These pneumonias can also be caused by this organism, Haemophilus influenzae. That influenza, by the way, has nothing to do with influenza. It does not cause influenza, although it is a risk, can cause these respiratory tract infections. But remember, I told you also, Haemophilus can also cause a meningitis as well. This is a particular risk to children. This pneumonia, as you get older, you develop strong immunity to Haemophilus. But in children, this vaccine, the Hib vaccine, Haemophilus influenza B, and that refers to the toxin, one of the toxins that it produces. Mycoplasmal pneumonias, these are often called walking pneumonias. And these are strange pneumonias. It's definitely a pneumonia. You can, if you X-ray, you can see that there impacts on the alveoli. But they're caused by a strange organism called a mycoplasma pneumoniae. It is bacterium, but it has no cell wall at all. It has to live under very, very specialized conditions. It causes a mild illness. And the only reason it's important is it's very common in residences, in dorms and residences, that you get these epidemics of this passing through. And over a matter of weeks or months, you have repeated incidents of people becoming ill. But it really is a mild, generally a mild illness. And if it's recognized at all, it's treated with tetracycline. So the next disease is really a relatively modern disease, which is rather strange. But this is truly a disease of modern life. This is legionellosis, caused by an organism called Legionella pneumophila. And Legionella pneumophila is a rod. You can see it here. It's a gram-negative rod. And it's a normal part of any aquatic ecosystem, any freshwater aquatic ecosystem. Basically, you can go there and you can find Legionella growing there. There are several species, but the one which causes the most dangerous illness is this one, Legionella pneumophila. The problem with Legionella pneumophila is that it grows very well in things like air conditioners. It grows very well in biofilms that form in anything which has a constant source of moisture. For example, in an air conditioner, it will grow in the drip trays. It will grow on the piping where water drips down, etc. Often it will grow, for instance, in the spring, for example, it may grow before the air conditioners are even switched on. And then when the air conditioner is switched on after it's been sitting for a while, the air conditioner whips up a spray and broadcasts that spray through its ducts, through central air conditioning, and can broadcast this bacterium. And this was recognized. There was a convention of American legionaries, veterans, all elderly gentlemen meeting in Philadelphia. And they actually, a large number of them suddenly became ill, and a large number of them died. And this mysterious respiratory illness, a very high fever, and a very virulent pneumonia, which had a high mortality. And it was eventually recognized that this new organism, what had brought it into the human realm was modern technology, the air conditioner. We still have outbreaks of Legionnaire's disease. In fact, 2 years ago or so, there was an outbreak in the Bronx, and several people died. And it turned out it was an old air conditioner on the top of a building, which was spraying out spray onto the street below. And it was passers-by walking in the street who actually got the disease. There is a milder form, which young people tend to show up with the milder form called Pontiac fever. But in older adults, it really is it can be very serious. It can be serious in anybody, but it is a very virulent pneumonia, again, treated with antibiotics. Okay, so I'll leave it there for the day, and I'll see you on Monday.